Good evening. I want to welcome everyone to tonight's COMS educational webinar. If I don't know you already, my name is Chad Robertson. I'm the president of the COMS. This is our first webinar of 2022, and it's been almost 2 years to the date since we started doing webinars due to the onset of the pandemic. To date, all the webinars, we've received great feedback regarding them, and I'm sure tonight's webinar will be no different than that. Now that spring's officially here, I'm sure many of you are just excited as I am to maybe get traveling again. And I want to take this opportunity to remind you that registration for the CMS annual meeting in Reykjavik, Iceland is open. If you go to the CMS website, you'll find a link for the meeting. You'll also see the program for the meeting, including the educational seminars that will be held during the meeting and the social events associated with it. Having recently attended the CMS Ski and Learn, I'm sure Ellen, under Ellen's leadership, the meeting in Reykjavik is going to be just as exciting as every other meeting that she is involved with, and I'm looking forward to seeing everyone there. I want to remind people to register early. The early bird deadline is May 2nd, but you might want to register before that because flights are only going to get more and more expensive as we get closer to the date. Anesthesia is a very important topic in oral maxillofacial surgery, and I want to thank Dr. Kevin McCann for ensuring that every March we get education on this important topic. Dr. McCann has been heading the driving force and heading up the Canadian Dental Society of Anesthesiology for many years now, and tonight he's arranged for a wonderful speaker. And without further ado, I'm going to turn the mic over to Dr. McCann to say a few words and introduce tonight's speaker. So I hope everyone enjoys things, and have a good evening.
Thanks, Chad. It gives me great pleasure to introduce tonight's speaker. Dr. Joseph Giovannetti is a dentist anesthesiologist and professor and chair of the Department of Dental Anesthesiology at the University of Pittsburgh School of Dental Medicine, and is also the anesthesia director of the school's Center for Patients with Special Needs. He is a recipient of the Leonard Monheim Distinguished Service Award from the American Society of Dentist Anesthesiologists and the J. Heidbrink Award from the American Dental Society of Anesthesiology. He has been actively involved in teaching at all levels of dental education, has authored numerous scientific articles, book chapters, and a textbook pertaining to pain and anxiety control in dentistry. He has lectured at professional seminars nationally and internationally, and is active in national dental anesthesiology professional organizations. I'm delighted that he has agreed to talk to us this evening, specifically about current pediatric anesthesia techniques, including trends, medications, and airway issues. Once again, we're going to take questions following the presentation, so please submit them through the chat line, where Dr. Tony Shahadi will moderate the question and answers. So please welcome Dr. Joseph Giovannetti, and everyone, thank you for spending your evening with us.
I want to thank everyone, for being here. This is exciting for me to be able to talk to you all. I want to especially thank Dr. McCann for the kind invitation to speak to your group tonight. Okay, and as Dr. McCann said, this evening's topic is going to touch on pediatric sedation and some of the airway issues that we come up with, and also some of the things that may go wrong with the airway during treatment and how to manage those things. I don't have any disclosures, and this topic is going to be broken into three parts. I'll first talk about some general pediatric points, the things about the airway, and then we'll talk about some specific drugs and techniques, and then we'll talk about some respiratory complications that occur during pediatric sedation and how to manage them. So I like to always start off with this slide when I talk about kids. This is one of my favorite movies, one of the scenes from the movies. I make my kids watch this movie every Christmas season. It's a Wonderful Life. And I always like the scene where Jimmy Stewart comes home and all of his kids run and they jump all over him. And he says to his wife, "Why do we have to have all these kids?" And I always thought, well, if that's the way I feel when I see a child in the dental office, then that child's going to go to sleep because they're going to be a difficult management issue. So kids are really a whole different animal because they don't really have a lot of coping skills because they really don't have much past experience with especially dental procedures, but anything in general. So anything that's new or unusual to a child is going to elicit some anxiety and some fear. So kids are naturally anxious and fearful about things that they're not used to. And their coping skills aren't that great. In an adult, if you have an adult with a lot of anxiety in the dental office, they might be able to control that anxiety because they have an incentive to, receive some type of quality dental treatment, be it a restorative procedure or, to have an offending tooth removed. But a child really has no incentive to benefit ratio. They don't feel that like I come into the office and I cooperate, I'm going to get this nice stainless steel crown, placed on. And so that's going to make it difficult. All these things make it difficult to manage the child. And what we really don't want to do is to damage their developing psyche. And this happens more often than we would like in the dental profession. And we've all seen these patients. I'm sure you all as oral surgeons see these patients all the time where their mouth is completely in shambles because it could be possibly because they've had a terrible experience as a child and that's ruined them for dentistry for life. And so the fear of the unknown, surprising them, pain, giving them, shots or using that type of verbiage, physical restraint and separation from the parent, all these things can damage the developing psyche of the pediatric patient. So we can use sedation or anesthesia as a tool to help prevent this from happening and get the child through a difficult appointment. And then as they get a little bit older and it becomes a little bit easier for them to cooperate, they can go into the normal routine of dentistry without having to be sedated every single time. Surgery itself is an anxiety-producing thing. And studies show that up to 75% of kids undergoing some type of surgery are going to develop anxiety. And that's associated with a lot of things like postoperative behavioral issues and emergence delirium, which we'll talk about because that's fairly common in the pediatric patient. And the goals of sedation are just like any other patient that we would sedate in the dental office. You want to facilitate quality dental care. That helps us do that. We want to minimize the disruptive behavior and give a good psychological response to treatment. Again, not damaging their psyche. We want to make sure that they're safe, and we want to return the kids to a physiological state as close to baseline as we can before discharge. So the first option is really no sedation. Not every child has to be sedated. I have sort of a skewed view of pediatric anesthesia because my career, about 90% of the patients that I saw in my private practice were pediatric patients. And so if I saw a kid, he probably had to go to sleep. But not all the kids have to do that. In fact, the vast majority can have treatment done without sedation. About 15% of the kids are going to require some form of sedation. And the younger patients are the ones that are going to have a greater indication for sedation, especially deep sedation or general anesthesia, because they lack the ability to understand what's going on. Around 36 months of age is kind of generally regarded as the age of reason. And so children below the age of reason, if they're going to have sedation, deep sedation or general anesthesia is going to be the norm for these patients. But certainly the younger the patients there are, the greater the risk to them becomes. And using enteral sedation, which we'll talk about a little bit, is not a guarantee for success. About up to 30% of these enteral sedations can fail. And the other thing about anesthesia in the dental office is that it's often objectionable to the parents. No parent wants to hear that their child wasn't cooperating and we have to put them to sleep to get this procedure done. So, So pediatric dentists have developed this kind of a point system that has been very useful in treatment planning and case presentations to the parent as far as why the patient might need to have sedation. And in fact, this becomes so popular that some of our insurance companies here in the States, this is a Medicaid provider, has used this form to justify reimbursement for anesthesia and sedation. And so you can see it's a point system. The younger the age, the more points. The type of procedures, the more procedures that need to be performed, the more points. You know, if they've had unsuccessful treatment in the past, or if they've got comorbidities, they get points for that. And so if they get 20 or more points, that justifies some form of sedation, usually a moderate level of sedation, and 30 points or more justifies a reimbursement for a deep sedation or a general anesthetic. And so something like this can help you in your practice to help quantify the need for sedation if you have parents that are resistant to that idea in the office. So let's talk about just a little bit about pediatric airway evaluation. So kids' airways are really a lot different than the adult airway, and just because of their anatomical makeup, they are going to be much more susceptible to the development of hypoxia during treatment. There's anatomical differences. There's a high demand for oxygen because their metabolism, metabolic rate is higher. And then they have a high alveolar ventilation to FRC ratio. And what that means basically is that children have very little reserve. Your functional residual capacity is like a reservoir of oxygen that keeps you oxygenated in between breaths. And the smaller the FRC, the less time that you have when you're apneic to stay oxygenated. Kids can hold their breath and turn blue. It's hard for an adult to do that, and that's because their FRCs are so low. So this is going to make them susceptible to hypoxia during treatment. Also, if you're going to do intubation in the office, their larynx is much more cephalad and anterior. The epiglottis is long and floppy, and so it's harder to visualize the vocal cords for intubation. Trachea is short, so there's a greater chance of doing endobronchial intubation. Fewer lung alveoli. Lung alveoli come to about a normal adult number at about the age of 10 or 12. And so before that, kids have fewer alveoli, and again, less gas exchange and the greater chance for hypoxia. Their nose passages are narrow. Their tongue is always large in relationship to their mouth, and kids have big tonsils and adenoids. And ENT or pediatricians really are reluctant to remove these things anymore. And so kids have recurrent infections, and they're treated with antibiotics, and then they have another one, and it goes on, and the tonsils and the adenoids just get larger and larger, and they obstruct the patient's airway. And we all know about the Malapati classifications, but kids usually have a class 3 or 4 Malapati classification. We don't see many class 1 Malapatis in pediatric patients. And so that's going to be another issue, making a difficult airway. And this is an example of a pediatric patient. This is actually a pediatric patient with Down syndrome. And you can see the narrow midface, the high vaulted palate, the malocclusion, small mouth, and large tongue. And, you look at that and you wonder, how are we going to get that patient to maintain their airway while they're sedated? And then these are the tonsils that we have to do a good exam with. And oftentimes we overlook this, but we should always do a good pre-anesthetic evaluation of the patient's airway and make sure that you're looking at the tonsils. Tonsils are classified according to a Brodsky classification, which is similar to the Malapati classification. Brodsky, this is a Brodsky 3, where the tonsils are protruding outside the tonsillar pillars and almost touching in the midline. A Brodsky 4 classification is when the tonsils are actually touching in the midline. And if you look at this patient, you wonder how they even breathe normally. How are they going to breathe when they're sleeping? And how are they going to breathe when you sedate them? And a patient like this, really is not the candidate for an open airway type of a procedure. This patient's airway needs to be protected in order to prevent that from happening. This patient obviously is going to have sleep apnea as well. But then kids always have reactive airways, it seems like. There's a high incidence of asthma in childhood that sometimes they can outgrow as an adult. There's exposure to secondhand smoke. I don't know how it is in Canada, but at least here in Pittsburgh, smoking is still very prevalent. And we see a lot of kids that have exposed to smoke in the household, and they come in with reactive airways. And also kids, especially around this time of year, they have frequent upper respiratory infections. And so, this is going to make children more susceptible to things like laryngospasm and bronchospasm during treatment. Okay. So a little bit about, let's see. Oh, I'm sorry, I skipped a couple slides. There we go. All right. So if a patient has an upper respiratory infection that's active, they can have a 5 times higher chance of having a laryngospasm during anesthesia, 10 times higher chance of bronchospasm, and an increased chance of desaturation. And what's hard about this is that even when this infection goes away, the airway hyperactivity can persist up to 2 months. And so how do we know when it's safe to manage a child if they have a URI or if they've had a recent one? So when you do your assessment, if the child has a URI, if they've got a purulent rhinitis or a productive cough, that's a contraindication to treatment, obviously, and the patient should be reappointed. If the patient's had a URI, say a week or 2 ago, and they come in and they still have this purulent rhinitis, they're not a good candidate. So assess the patient if they have a runny nose, but it's clear. Listen to their lungs. See if they, have them cough, ask the parent about their activity levels, if they're back to normal, et cetera, and their appetite, all that stuff. And really, you have to kind of use your gut feeling, are you feeling lucky today, basically, when you manage this type of patient. We don't really have a lot to gain by canceling cases if their lungs are clear, their activity levels are normal, and they've got a clear runny nose. But just be aware that the airway may still be reactive, and be prepared that you may need to manage these complications. I'm sorry, this is, here we go. Okay, let's talk about a little bit of management airway issues. So we all know how to manage an airway. I mean, this is like preaching to the choir, but you're going to have office staff that is trained to do this. If you have office staff turnover, if you hire new people, they need to be trained to recognize airway obstruction and how to manage that. So, we know that if patients start to snore or they're using accessory muscles to breathe, they have that rocking boat type of breathing where they're using intercostal and chest muscles, tracheal tug, and obviously if you're doing CO2 monitoring, you lose the waveform. And so how do we manage that? And this is just a quick video of just what airway obstruction is and how to fix it. We know how to do this, but again, train your staff.
Now Gary, lift his chin up. You don't even have to be aggressive, but that's good. Oh, look at the air pass through. Isn't that great? Just tilt his chin now without having to do the thrust, and just show him. That's good. Get your hand out of the way. That's perfect.
Okay, so we all know how to do that, but again, it's informational for your staff. Teach them how to do that. If you have patients in your office and they are deeply sedated and their airway, let their airway obstruct, and teach your staff how to manage that. Jaw thrust, chin lift, all the different airway maneuvers. Then your office has to be equipped with certain equipment, and it has to be sized appropriately for the pediatric population. And, as oral surgeons, I know that you're going to have referrals for pediatric patients all the time. And so you have to have the appropriately sized equipment, nasal cannulas, different face masks, bag valve mask device. And then you're going to have sized nasal airways, oral airways, and then some type of supraglottic airway, like an iGel or a King Lt Airway. And these things are all essential parts of your emergency airway cart. And then supplemental oxygen, obviously, we're going to be giving this to all of our patients. And these are the different devices that we can use. Typically, we're going to use during treatment a nasal cannula. And our nasal cannula, when we use this, can increase the FiO2 above room air by 4% for every liter per minute flow that we give. So if you're using, for example, 3 liters per minute through your nasal cannula, that increases the FiO2 by 12%. And so the patient is inhaling 33% oxygen instead of room air. And so you can increase their oxygen saturation or oxygen FiO2 by increasing the flow rate up to about 8 liters per minute. These are nasopharyngeal airways, obviously come in various sizes. You size these by placing it up to the patient's nair and then to the tragus of the ear. It should extend to that far. And then look at the patient's little finger. The diameter of their little finger corresponds to the diameter of the nasopharyngeal airway that you need. And so lubricate that up and place that. This is a good adjunct to use during deep sedation procedures with an open airway to facilitate maintenance of the airway during your treatment. Oropharyngeal airways are also sized. We size those by placing them at the corner of the mouth, and they should extend to the angle of the jaw. This is the supraglottic airways, and in the emergency situations, we are now going to the supraglottic airway over intubation. Intubation is something we all know how to do, but maybe you don't do it every day, and maybe it's been a while since you've intubated a patient. And especially in the pediatric population where visualization of the vocal cords are sometimes difficult, in an emergent situation, it's really not the way to go. The way to go would be using some type of a supraglottic airway. And we're recommending the iGel. It comes in different sizes based on patient's body weight. And so you select the appropriate size. And this shows a pediatric patient having one inserted, and you can see the ease of insertion.
Does it have sound?
Now, we want to just to press on the chin a little bit. We're going to put her in a sniffing position. Doctor, push down on the chin. Place this in. Push this up against the palate as you go. And then just insert. That's it. Check the patency of the airway. Wonderful. Okay. If we had a capnograph on this, you'd see a wonderful capnograph wave. She's ventilating very well right now, and you can see the ease of insertion. That's it. We can cut that.
Yeah. So what's nice about that is that it really doesn't take a lot of training to insert that. You can watch this on YouTube a few times and practice on a mannequin if you have one, and it's done. It's very easy to use. The other type of supraglottic airway, which also is very effective, is the King Lt Airway. And they also come in various sizes depending on the patient's body weight. And this is a little different in that you insert this and it goes directly into the patient's esophagus. The tube is too large of a diameter to go through the trachea. So when you insert it blindly, it goes right into the esophagus. You inflate these two cuffs, and the one cuff blocks off the esophagus so that it prevents regurgitation. And then the larger cuff blocks the pharynx and creates a seal. There's holes in between those two cuffs, so when you attach your bag, you can ventilate the patient easily. And this is what it looks like at a cross section in place. You see the smaller cuff is in the esophagus, and then we can ventilate easily. And then this is a little video that shows the insertion of this.
Okay. This is a King Airway, a little different from some of the other traditional airways. We're going to tilt the chin down, place this along the lateral border of the tongue, slide it down past the base of the tongue, and then rotate it till it fits in. Push it down till you meet some resistance, and then we fill the cuff with 60 cc's. Should be in place. Secure the tube, but you can see that we can just immediately ventilate. Airway.
So if you're listening there, you could hear the pulse oximeter in the background, and you could hear the tone changing, was decreasing. The patient was desaturating. But as soon as he put that in and put the bag on there and started to squeeze, you could hear that tone change. It was coming back up again. So he had the airway in the proper position, and he was easily ventilating that patient. And so again, a very easy way to secure the airway.
Okay.
If you want to intubate a patient in the dental office, I would recommend using some type of video laryngoscopy. In an emergent situation, you're going to get the best visualization, the quickest way with video scope versus a direct laryngoscopy. And this is an example of the type of view that you get on these instruments. A video laryngoscope can make a difficult airway easily visualized. So I would recommend that if you want to go to the intubation route. Okay, so let's talk a little bit about some of the techniques that are out there to sedate these patients. And then basically everything's been tried in pediatrics. So, you know, whatever we have, let's try it on a kid and see if we can get him sedated. So we give them oral medications, inhalational agents, we give them IM injections, we shoot things up their nose, we now are making them inhale drugs, and then we can do deep sedation or general anesthesia. So here's a bunch of different drugs that may or may not be useful in pediatric sedation, but all of these drugs have been used at one form or the other over time in pediatrics. And we'll talk about some of the ones that might be more useful than others. Routes of administration, all the drugs on the left, the oral drugs, these drugs have all been used for oral sedation, mixing them up in combinations, you know, like sort of mixing up a cocktail. The drugs on the right have been given intranasally, and they've been studied for their efficacy. Inhaled, the newest thing now is to try to nebulize some of these medications. Ketamine and dexmedetomidine are the drugs that have been studied most with this type of technique. And then we have the intramuscular drugs as well. Ketamine, again, and midazolam are the most popular and actually the most effective. I want to say a word about chloral hydrate. I don't know if anybody is still using that. In Canada, in the United States, it's no longer available. It's no longer being manufactured. And the only way that it can be obtained is through a compounding pharmacy. This drug has been around since the 1800s. If it was a new drug today, it would never be approved because of the issues with it. It doesn't work that well. You know, it's varied in its efficacy. And basically, it's sedation with alcohol. When you ingest this drug, it's transformed into trichloroethanol. And we all know that the alcohol has varying effects on the individual. You can get a nice, happy, and cooperative drunk. You can have a nice, compliant person. You can have a sleepy drunk. You can have a mad drunk. You can have a belligerent drunk. And you never know what you're going to get when you give this to a pediatric patient. And that's why the efficacy is so variable. It also sensitizes the heart in the same way that halothane used to. If anybody used halothane in their training, sensitizes the heart to the effects of catecholamines. And so that means that vasoconstrictors in your local anesthetic can produce significant cardiac dysrhythmias. And it also has a metabolite that's a known carcinogen. So it's really not advisable to be used anymore because of all these issues. And now there's better drugs out there. Chlorohydrate used to be the mainstay for pediatric oral sedation, but no longer. If you're a fan of the film noir genre, you have the hard-boiled detective with the fedora and the trench coat, and then the femme fatale, when he's not looking, places a couple of different drops in his drink, and the next thing you know, he's unconscious, and they either beat him or rob him, and that is chlorohydrate, and that's known as a Mickey Finn. There was an actual bartender in the south side of Chicago in the late 1800s. His name was Mickey Finn. And if you went to his bar and it looked like you had a little bit of money, he would slip some chlorohydrate into your drink. When you'd become unconscious, he'd beat you up, throw you out, rob you, and throw you out into the street. And that's where this terminology came from. And that's basically all that chlorohydrate is good for anymore from a historical standpoint. Do not use this in your pediatric sedation. I'm just talking about that as a historical reference. What's more common in pediatric oral sedation is the benzodiazepines. And so these three can be used effectively in the pediatric population. Most commonly, we use diazepam or midazolam. Midazolam comes as an elixir, and you can give it according to that dose range in pediatrics. Most pediatric dentists use 0.5 milligrams per kilogram as their dose for oral midazolam, but you can give it a maximum of 20 milligrams. And it seems like a high dose, but there's so much first pass metabolism going on with this drug that the bioavailability is acceptable. So that's why that dose range is way higher than a parenteral dose. Diazepam, good old Valium, is also a very good pre-medicant, and triazolam can be used as well, but in the older child, I would say, a child maybe over the age of 10 and weighs more than 60 pounds, this might be a good drug for them. But a lot of pediatric dentists like to give combinations. And so these are different combinations that have been used. I've highlighted the ones that are the most commonly used now. And we can see that meperidine and hydroxyzine is still very popular. That's Demerol and Vistaril in those doses. The original triple cocktail that they used was meperidine, chlorohydrate, and hydroxyzine. But that's been replaced by meperidine, midazolam, and hydroxyzine, or morphine, midazolam, and hydroxyzine. These are also two very common and very effective oral combinations in these doses. A newer drug combination is midazolam with ketamine. Ketamine does not come as a oral elixir, but you can use the parenteral form of ketamine in that dose range and mix that with the midazolam elixir and have the child drink that in that dose. And that's very effective. It's a fast onset, 15 to 20 minutes, and the patient is sedated to a moderate level. This is an example of intranasal sedation. You can get a little atomizer like this and attach it to your syringe with the medication in it. And the drugs that have been studied in this form are midazolam, dexmedetomidine, the combination of midazolam and ketamine, combination of dexmedetomidine and ketamine, and even sufentanil and dexmedetomidine. And if you look at the literature, you can see papers on all of these different things. The most effective has been shown to be midazolam ketamine combination, or the dexmedetomidine ketamine combination. This is an example of nebulization of medications and the drugs here. I have a reference listed here, but ketamine, dexmedetomidine, either singly or in combination. And it's like a nebulizer that a child would use for asthma. So if they are compliant enough to do this, you could put the medication into the nebulizer and have them inhale it. Okay, these techniques with oral drugs are going to produce a moderate level of sedation. And the best success rate is between 60 and 80%. You're going to have a lot of failures with moderate sedation, enteral sedation in pediatrics. It's all about patient selection. It doesn't work on everybody. It's not like, all I have is a hammer, so everything looks like a nail. You're going to have to choose your patient, so that you have the greatest chance for success. There's always going to be failures when you do minimal or moderate sedation. And most of the problems that we see with this is when doses are given in excess of what I've described, or the patient's been redosed in the same appointment. Remember that we have nitrous oxide available to us, and nitrous oxide is one of the most common drugs given to pediatric patients. It's very effective in the pediatric population. So if you're going to use oral medications, you can supplement it with inhalational agent like nitrous oxide and increase your chance of success. But sometimes you're going to need a little bit bigger boat. And so that's when we're going to look into deep sedation or general anesthesia. And so really, ketamine is the kind of the drug that we're going to rely on in the dental office for these types of patients. This is one of these drugs that really you can't do pediatric deep sedation without. It works really fast, within a minute IV, 5 minutes IM. So it's the fastest IM sedative that we really have out there. 3 to 5 minutes after an IM injection, you have an effect. You can even use it orally, as I said. The doses that we use that are listed there, 1 to 2 IV and 4 to 6 IM, are general anesthesia doses. We use what's called a stun dose. I want to use ketamine IM so that I can facilitate venipuncture and get the patient ready for my other medications that I'm going to infuse. So we call this a stun dose. It's like hitting the child up the head with the side of the head with a 2x4. It's going to stun them. And so 2 to 3 milligrams per kilogram IM is our stun dose. And you might call that the ketamine dart. And so we're going to use ketamine. I like to mix glycopyrrolate with it because we know ketamine increases salivation. And you can add midazolam to that as well to increase the duration of action. And so that would be your typical ketamine IM to facilitate the start of the procedure. If you're doing a short procedure, that's going to be a few extractions on a pediatric patient. This might be all you need. Give this injection, and you've got about 30 minutes of working time. Okay. But if you're going to do a little bit longer procedure, then you're going to have some other drugs to add. And so we like to do a deep sedation by infusion of medications rather than intermittent boluses, because you have better control over the level of sedation and you can easily adjust it up or down. And so the main drugs used in these infusions are propofol either by itself, or propofol and remifentanil, or propofol and ketamine combinations. You can use them as separate infusions, and so you run propofol in this dose range and remifentanil in that range that's listed there. Some practitioners like to combine remifentanil and propofol in the same syringe, and so you do that by adding 100 micrograms of remifentanil into 200 milligrams of propofol, and then you infuse it as that propofol rate. The combination of propofol and ketamine is also very effective. You can combine those in a single syringe, placing 50 milligrams of ketamine in 200 milligrams of propofol and infusing that. And that's also very effective. And you can adjust the infusion rate to the patient's respiratory rate. Patients are going to breathe spontaneously during this, and you can adjust the effusion up or down based on the patient's responses. Adjuncts to this would be the use of dexmedetomidine. It can be given in divided doses. We'll talk a little bit more about this. This drug is very effective in potentiating the effects of your other medications so that you can decrease the infusion rates. Also, it helps prevent emergence delirium, which is common in pediatrics. We can use dexamethasone as an antiemetic as well as ondansetron. And so here's a couple of examples of this. This is a patient that's going to have an office procedure with an open airway using this technique. And this patient is 9 years old, history of autism, and the procedure is going to be an exam under anesthesia. The patient's not cooperative, so they don't know really what the treatment plan is. And then they're going to fix everything in one appointment. This is at a pediatric dental office. So here's our patient, and as we walk into the conference room, he gets up and tries to run out of the room. In a few minutes, we give him a shot of ketamine as described, and that's kind of him relaxing. We carry him on into the operatory, and this is the typical appearance of the patient after they've received an IM injection of ketamine with that stun dose. He's breathing spontaneously, but he is detached. He's in this catatonic-like state. Now we can take our time. We can attach our monitors, hook up our IV, and then we start our infusion. The dentist goes in and does his exam, radiographic, hard and soft tissue exam, develops his treatment plan. Here's our infusion pump with propofol and remifentanil going in through the IV. And then the dentist just does dentistry like he normally would. And you can see them maintaining the airway. The assistant's trained to keep the chin up, and they're using rubber dams so that they're not getting things down in the back of the throat. We can use that C-sponge or some type of a pharyngeal partition to keep things from going down the throat to prevent water or blood getting down there and causing laryngospasm. And you can see we're monitoring, got a good CO2 waveform, the patient's breathing spontaneously, all the vital signs look really good. And so that when we are approaching the end, we just turn off the infusion. These drugs wear off very quickly. Within just a few minutes, the patient recovers and they can be ready for discharge very, very quickly. Here's a similar case, only this time we're using a more protected airway. We're using an LMA, this time a flexible LMA. This child is also a similar history, and he has a mesiodens that needs to be taken care of. So after his shot of ketamine, we are giving him a little bit of oxygen in preparation for insertion of the LMA. We're going to have an IV in place. We're going to give him a dose of propofol so that we can facilitate placing the LMA. This is a flexible LMA. It's being taped off to the side. It's attached to our breathing circuit, so we can assist ventilation if necessary. And there's our propofol and our remifentanil being infused. And the surgeon goes in and he can complete the procedure without having a problem with the patient's airway. Here's one in a dental office setting doing general dentistry, and we don't have an anesthesia machine to hook up to the LMA. So again, we're going to insert that LMA just like we did in the previous patient. And then we're going to hook up this device. This is like a T-piece. And we have one area that we can, look at monitor our end-tidal carbon dioxide. And this is where our oxygen is being delivered right through here. Patient's breathing spontaneously with our remifentanil propofol infusion. And if we need to assist ventilation, we can either attach our bag mask or bag unit, or we can use a Jackson Reach type of circuit to help ventilate this patient if necessary. And there's the setup. and then the dentist can go in there and do the procedure. You can see the C-sponge there protecting the airway. And then the dentist goes in and does his thing. If you want to intubate the patient in the dental office, you don't necessarily need to have a general anesthesia machine. You can do this with the same infusion techniques that I'm talking about. And you can use something like this. This is called a Kab Absorber. It's made by King Systems, the same manufacturer that makes the King Lt Supraglottic Airway. And all this is a carbon dioxide absorber, similar to what you would have on your anesthesia machine. And you see you have an attachment here for your bag, your resuscitation bag, and you have attachments here for your breathing circuit, and you have an APL valve, an exhaust valve, and you have an oxygen hookup in the back of this. This attaches to an IV pole. So this is what it looks like set up. It's attached to the IV pole. We have our breathing circuit and our bag hooked up to this. And you can see. And then we intubate the patient. This is a nasal intubation. And after we intubate the patient, we attach the breathing circuit, the monitors, and then the patient's spontaneously breathing with the remifentanil propofol infusion. But if we need to assist ventilation, we can do that manually by squeezing the bag. So we can give a total intravenous anesthetic and intubated in the dental office. We don't need an anesthesia machine, and very effective. If you want to use anesthetic gases, they have all types of different anesthesia machines. You can get the full-size operating room type, or you can buy a desktop machine that's portable. And this is a desktop machine that we have in on our clinic to demonstrate to our residents that this is available to them if they would choose to use something like this. But it has everything that an anesthesia machine would have, a larger anesthesia machine. It's got your vaporizer, your flow meters, a ventilator, and we can intubate and run anesthetic gases if we need to. Okay. When kids wake up, sometimes they're not very happy. Sometimes they're really nice going to sleep, and then when they wake up, they get like this. And we want to prevent that. The best way to prevent that with a medication is the use of dexmedetomidine. Precedex is the brand. This drug is an alpha-2 agonist drug that works on alpha-2 receptors both in the central nervous system to produce anxiolysis, sedation, and they're also good analgesics. Dexmedetomidine produces excellent analgesia. Also, it works in the autonomic nervous system, and it decreases sympathetic nervous activity, and so it sort of attenuates the stress response. And to prepare dexmedetomidine, it comes in a 2 ml vial of 200 micrograms total. It's 100 micrograms per ml. You dilute that vial to 50 milliliters so that you have a final concentration of 4 micrograms per ml. And that's the concentration that you use to deliver to the patient. And the dose is described here. It's 0.25 micrograms per kilogram. And typically we administer half and observe the response, because sometimes it can slow the heart rate a little bit or lower the blood pressure. So we don't want to give that whole dose right up front. We want to give half, see how the patient responds. And to prevent emergence delirium, it's best to give this drug about 15 minutes before the end of the procedure. You can give it if the patient wakes up and they're in delirium. You can give this dose as a full bolus to attenuate that response, stop that response. Okay. Let's finish up by talking about some of the common pediatric respiratory emergencies. And actually, if you're going to have issues in pediatrics, it's always going to be respiratory. And of course, if you let it go far enough, then it can lead to cardiac arrest. But this is where the emergency starts in pediatrics. So we'll talk first about laryngospasm, and that's the leading cause of cardiac arrest in children. It's from laryngospasm. Kids have reactive airways. We know what that is. It's a spasm of the vocal cords, and It's a protective reflex, but in deep sedation, the patient kind of loses that protection. And what happens is you get some water or a profound pain stimulus or some blood back there. It touches the vocal cords. It causes them to close, and then they don't reopen, and the patient has an airway obstruction. Treatment for that is deepening the anesthesia. If you deepen the level of anesthesia, give a bolus of, say, propofol, then you can relax the patient, open up those vocal cords. Suction to suction out the offending material. So we need a Yankauer suction or a tonsil suction as part of our equipment. Use our airway maneuvers, sustain positive pressure, and we may need to go to paralysis if this doesn't work. So this is an example of a patient who's having a laryngospasm. So you can hear that kind of crowing noise that we always talk about, and you can see the retraction of the suprasternal notch, and that's characteristic of laryngospasm. So look for those. I like to use a pretracheal stethoscope along with my other monitors during pediatrics because you can really hear when that happens, and so it's a good idea to use that monitor as well. There's a thing called the Larson maneuver for laryngospasm. I have a video that shows that real quick.
Laryngospasm, a common complication after extubation, can be treated by the Larson maneuver. To perform the maneuver, first locate the laryngospasm notch behind the lobule of the pinna of each ear, anterior to the mastoid process of the temporal bone, and posterior to the ascending ramus of the mandible. Press the middle finger firmly on the notch in a cephalid direction. Some degree of jaw thrust may also be applied.
Okay, so you can certainly do that as one of your airway maneuvers. You know, if a patient has a laryngospasm, you should do a jaw thrust. So you can sort of do your jaw thrust and the Larson maneuver at the same time. I can tell you just from my own experience that I have had no luck with success with this Larson maneuver. Okay, what I have had success is with positive pressure to the airway, sustained positive pressure. And so this is an example showing how to do that. You run a high flow through your resuscitator and like 10 to 15 liters per minute. And you get a really tight seal on the face mask, open the airway and put a sustained pressure. And sometimes you can use your gut. I've got a good extra roll here. I put the bag on, and when I put sustained pressure, and I can put a high positive end expiratory pressure on that airway, and you can force those cords open with repeated effort. Things that are predisposing factors to laryngospasm are reactive airway diseases. Okay, so we talked about these already, but light anesthesia and pain stimulus can also cause that, aside from secretions in the airway. So how do we prevent laryngospasm? Well, keep the patient conscious. Conscious patients do not have laryngospasms. They'll cough and they'll sputter and they'll choke, but they'll clear their airway. So it's only when we get into that level of deep sedation. Okay, avoid stimulating the vocal cords. And we know that if you have one and you can't fix it, then these are the complications associated with that. But another really successful way that I would recommend using in pediatrics especially is the chest compression treatment. And this is a really interesting study that I came across that looked at this. This was a study that went on for 4 years. They looked at pediatric patients between the ages of 3 and 12 that were having tonsillectomies. So, okay, they're having things done in their airway, just like dentistry. And the first 2 years of this study, if a patient had a laryngospasm, they treated it with positive pressure via face mask. The next 2 years of the study, if the patients had laryngospasms, they treated it with chest compression, like doing a chest thrust. And what they found was they studied about 1,200 kids, And both of the groups had about the same incidence of laryngospasm. About 8% of the cases had laryngospasm. And what they found was in the chest compression group, giving the patients with laryngospasm had a chest thrust, almost 74% of them were successfully treated when they had the chest thrust. Only 38% of them had successful treatment when they were given positive pressure to the airway. And so what you're doing here is instead of putting positive pressure from on the outside, you're putting the pressure from the inside. When you push on the chest, you're blowing air from below out and opening those vocal cords. And this is especially effective in kids because their chest compliance is a lot more than an adult. And so you have a greater chance for success in creating this pressure by pushing on the chest. So keep that in mind when you have laryngospasms in pediatrics. Also, the use of lidocaine can be effective in preventing laryngospasm because lidocaine obtuns the airway reflex. And you can give lidocaine IV, and it can be effective in obtunding that reflex and help preventing or be prophylactic against laryngospasm. Then I wanted to say a word about paralysis because this is, if these methods don't work and the patient's desaturating, you've got to get air in. So you can do that by paralyzing the patient. And you can use succinylcholine or you can use rocuronium. And so dose here in pediatrics is listed for succinylcholine. Let's see here. Oh, okay. And then this is rocuronium. So two different mechanisms of action. Succinylcholine is a depolarizing muscle relaxant. Rocuronium is a non-depolarizing muscle relaxant. The dose is listed here. And its onset is just slightly slower than succinylcholine, but not much. The downside is that it lasts a lot longer. Okay, so let's look at some cost comparisons and talk about that. Both of these drugs are relatively inexpensive. These are costs that we have here at the University of Pittsburgh. So the costs may vary, but these drugs are not expensive. And so if you have a child here that we're going to give 20 milligrams of succinylcholine to break laryngospasm, that costs about 80 cents. If you have a 20 kilogram child, that's 12 milligrams would be the dose of rock, and that costs about 72 cents. So to break the laryngospasm doesn't cost much. But what do you do after you give rocuronium? You have to reverse that because it's a non-depolarizing muscle relaxant. It lasts up to an hour. And even if it seems to be worn off, you can't just discharge a patient. They need to be adequately reversed. This new drug out there now to reverse this drug is Sugammadex. Sugammadex acts differently than other reversal agents like neostigmine, for example. Sugammadex actually acts to encapsulate the rocuronium and remove it from the receptor site. And so you can immediately reverse an intubating dose of rocuronium with this drug. Rapid reversal is 16 milligrams per kilogram. I have cost list here. And so if I wanted to give rocuronium to that 20 kilogram kid to break his laryngospasm after that successful reversal would mean 320 milligrams of this drug, and that's going to cost about $160. For an adult, 70 kilogram adult, that would cost about $560 to reverse that patient. But in comparison, if you use succinylcholine as your emergency drug, at least here in the US, if we have sucks even for emergency use to break laryngospasms, we're required to have dantrolene because succinylcholine is a triggering agent for malignant hyperthermia. And so there's two different preparations of dantrolene. One is Dantrium or Revanta, and the other one is Ryanodex. Dantrium comes in these 20 milligram vials, but you need 36 vials of this on hand. and that costs about $3,600, about $100 a vial. Ryanodex, you only need 3 vials of that. It's easier to prepare, and but it costs about $2,000 a vial, so around $6,000 for this particular drug. So when you're thinking about, cost effectiveness and effectiveness of the drug, succinylcholine and rocuronium are about equally effective to break a laryngospasm. But then you have to look at cost for reversal or cost of buying the dantrolene. And I think it's much more cost effective to use the Sugammadex cost versus the dantrolene cost. And then how many laryngospasms do you have to actually give drugs to fix? Very few, because the vast majority are going to be managed by these other methods. So another thing that can happen is bronchospasm, and I think this is a much more scary emergency than a laryngospasm. All laryngospasms break eventually, but bronchospasms don't. So patients with reactive airway disease are prone to bronchospasm, and we've got to get the drugs down into the bronchioles. This is an example of a patient having a bronchospasm. They say this patient's really struggling to breathe, and they're obviously wheezing, and so they're going to become extremely hypoxic. And so this can certainly happen during your treatment. During treatment, you can recognize this. If you're monitoring with end-tidal CO2, you're going to see a change in the waveform. You're going to see more of a peaked waveform, like a shark fin type of waveform that indicates a lower airway obstruction. Management is with 100% oxygen and positive end expiratory pressure, deepening the anesthesia if they're intubated, ruling out kinks in the tubes and things like that. But you have to administer a bronchodilator, through the endotracheal tube circuit. We use albuterol. You can also use epinephrine there as described. In a non-intubated patient, the treatment is basically exactly the same, but instead of administering through an endotracheal tube, we have to administer it through the bag valve mask device. And so we have adapters on these devices that we can be attached, and we can administer our albuterol this way and then squeeze it into the patient's lungs effectively. Also, if you have a patient with a reactive airway, prophylactically prior to treatment, you can give them a nebulized treatment with albuterol. The last thing is negative pressure pulmonary edema, real quickly. This happens mostly in the open airway case or in a patient that has a laryngospasm. But if you're doing the deep sedation with the open airway in the way I described, and the case takes an hour and a half to 2 hours, which is a long procedure in a pediatric patient, the patient is going to be breathing against a partially obstructed airway for a period of time, because no matter how well you're maintaining that patient's airway, there's going to be some degree of obstruction because you've got your hands in there and you're moving the head around. And even though everything looks okay, eventually the work of breathing is increasing, and the child's just going to wear out. And so they're going to create this breathing against this partially obstructed airway, and they're going to increase the pulmonary capillary pressures to a degree where fluid is going to start to leak into the alveoli. And I've seen this many times in cases when they've gone too long. I'm listening through a stethoscope, and I can hear the breath sounds change, and the wheezing start to occur, and the oxygen saturation start to fall. So a long case like that in pediatrics, patients should be having a secure airway with either an LMA or an endotracheal tube. Okay. breathing against the partially obstructed airway is a very important cause. It's very common in pediatric sedation that goes too long, or the airway is not maintained appropriately. Okay, that was a lot. I went over a little bit of time, but thank you all for your attention, and I'll be happy to entertain any questions.
Dr. Giovannitti, thank you very much for the presentation. I thought that I would hopefully prime the audience by throwing out the first question. I really focus on identifying the potentially difficult airway prior to even thinking about putting someone off to sleep in the office. And my practice is predominantly adults. And so there's a few things that I really focus on. Are there any really big red flags in the pediatric airway that when you look at, you just kind of say, this may not be the best environment for this young child?
Well, yeah, the BMI problems in pediatrics is almost epidemic. The kids are getting way bigger; they're way up there on their percentile charts. Kids that are in the 92nd percentile of height are susceptible to obstructive sleep apnea, and so I always want to screen kids for OSA. And ask the questions to the parent about snoring, about daytime tiredness and things, and also want to do a good tonsillar exam, and look at neck circumference, because those are the big red flags. Even if you have a child who's obese, but it's mostly in the lower portions, and they sort of have an actual neck that you can visualize, then I'm not too concerned about that. But it's really neck circumference and tonsillar size and histories of snoring that bother me. Also, reactive airways. So I'm always assessing them for, recent URIs and if the parents smoke in the home, because that's also a predictor of either bronchospasm or laryngospasm. But those are the main things. And then also syndromic patients, that you'll see with various airway issues, especially the Down syndrome patient is sort of the poster child for a bad airway.
Yeah. Good. Thanks.
So there's a couple of questions from the participants. I'll just start off with one of the first ones. In the context of needle-phobic patients, can you comment on the use of the EMLA patch as an adjunct?
Okay. EMLA patch can be effective, as can a topical spray. The EMLA patch has to be applied for at least an hour, sometimes longer, and so that can be prohibitive. If the patient comes into the office, so you could prescribe that ahead of time and have them place that on there. There are also devices that are sort of needleless devices for injection, but they don't get deep enough into the muscle for you to have an effective IM injection. So yeah, needle phobia is really a problem in kids because a lot of them have that. But some people like to give inhalation inductions. If you have an anesthesia machine, you can use sevoflurane, but I find that to be more traumatic than giving the kid a shot. So if you kids go to pediatricians all the time and they get shots. It's not like it's a surprise, but you have to prepare the parent adequately, have the parent hold the child for you, and then in and out quickly. The child may cry a little bit, but the drug works so fast, and really I still feel that's the best way to do it. You can give an oral pre-medication ahead of time, or you can even use some nitrous oxide, but again, times constraints sometimes preclude this.
Okay.
In the office.
Is there any issue? I think that one of the adjuncts, or parallel to the question on the EMLA patch, is a comment on local anesthetic toxicity in pediatric patients. Is that?
Yeah. Actually, I had that on my presentation, but I cut it out because I was going too long. But let me talk about that real quickly. Local anesthetic toxicity in pediatrics is a big deal because there's some papers out there that have looked at pediatric morbidity and mortality, and up to, in dentistry, up to 40% of pediatric fatalities have been due to local anesthetic overdoses. When you use sedation, that can potentiate local anesthetic toxicity. And so the AAPD here has recommended lowering the doses of local anesthetics when kids, when they're sedated, to 4.4 milligrams per kilogram of body weight for lidocaine, 2% with 1 to 100,000 epinephrine. The manufacturer's recommended dose is 7 milligrams per kilogram. So it significantly reduces the number of cartridges that can be used. Articaine is another popular drug that's used in pediatrics, and the dose is 7 milligrams per kilogram for that. It has some margin of safety because it has an ester side chain that's hydrolyzed by plasma esterases, and so the toxic potential is less. So we can give a higher dose, but it comes as a 4% solution. Right. So you end up giving fewer cartridges, but you can use up to that much as well. But yeah, you do need to be cognizant of the total dose of local, because that's certainly going to build up and cause an issue with these kids.
Right. Just from a practical point of view, getting back to the ketamine dart, which I'm fascinated by on that occasion to use. So if I look at the formulation, the 2 to 3 milligrams per kilogram that you're recommending, and say, I don't know, what I'm getting to the point is, it looks like the volume of it because ketamine is 10 milligrams per ml. It comes
as a 100 milligram per ml preparation.
I see.
And so that's what you would use. Okay. And then, in a kid, the minimum amount that you should give a child is 50 milligrams. Even if your calculations come up with a lower number, 50 milligrams is going to work. But then after that, you can give it up to 3 milligrams per kilogram, and you may just give 1 or 2 mLs of it, the total volume.
Right. I guess I was imagining a 15 ml syringe with the
right. Yeah, that's a lot.
Yeah, that's a lot. I'll just move along with the questions just so we can get to them. If you have a registered nurse that works for you in your clinic, do you feel that it's mandatory for them to have PALS certification? And is it effective for anesthesia assistants?
Yeah, I think that if you're going to work in pediatrics, you should have a PALS certification. Anybody who's involved with the treatment of the child. That being said, PALS isn't really the greatest anesthetic emergency management tool, but certainly it's all we have. And so that's mandated here. That everybody has to have PALS if they're working in kids.
Right. I'll just jump to a next question. Well, actually, so if PALS isn't necessarily, I'll just expand on that for 2 seconds. So what would be your suggestion as an alternative in the context of that response?
Yeah, I don't know, because there's not really much out there that's available to do that. And PALS is kind of the standard, so everybody gets that. I mean, it's there's really nothing good for pediatric emergency simulation out there that I know of.
Okay. Another question for you, and we're coming back to the needle phobic or uncooperative child. Prior to IV insertion, what's your preference, oral sedative or ketamine dart? I think we kind of know the answer to that now, right?
Yeah, that's my answer. I like ketamine. It works all the time. Oral sedation doesn't work all the time. And so now you've given the child the drug, you're waiting for it to take effect. You bring the child back, it's not working, and you end up having to give them a shot anyway. And so you're really traumatizing the child. So I think the least trauma to the child is to give them a IM injection in an area of the office, not the operatory. A private area where you can have the parent, and just if the parent's prepared to hold the child properly, you can do this in and out, and it's very low trauma to the child.
Okay. Question regarding are there any what would be some of the contraindications for the use of ketamine intravenously?
The only contraindication to the use of the drug would be if the patient had significant cardiovascular issues or hypertension that was not controlled. Otherwise, ketamine, can be given to just about anybody. Most of the complications that we've seen with ketamine in the past have been really with high doses. One of the ways that we used to sedate children was to just give them ketamine up front and then just ketamine IV and keep giving it until the case was over. And we saw a lot of excessive salivation, and we saw a lot of delayed recovery, and a lot of nausea and vomiting, and a lot of emergence delirium. But using low dose like we do, this is basically, in a kid, this is the only dose of ketamine that they get. They get this IM injection, and then we switch to another technique. And it's such a low dose that we don't see all these other problems associated with it.
Okay. Another question here that are coming in. So what would your preferred management be for the ADD, attention deficit disorder child? Would you recommend that they take their regular medication regimen on the day of surgery, or no? No.
Yes, I would. I would have them take their medication. That's that's what they're used to. I think it's better to have them on their medication rather than off of it. So take your medication as usual. And I would still, if the patient needed it, I would still give them an IM ketamine injection and go from there. Same technique.
Just out of curiosity, one of the questions that was asked is, where's your preferred site for the IM ketamine?
The deltoid muscle. That's going to be the fastest uptake. But if you can't get it in there for some reason, the anterior thigh.
Okay. I guess you've touched on this, but I'll ask it anyways in case I didn't interpret the question. Is there a higher incidence of emergence delirium in children who receive ketamine?
Not at that low dose, no.
Okay.
No.
Okay. Here's a question. Can you comment on the management of pediatric patients who've tested positive for COVID?
Well, if they've tested positive for COVID, they should not be treated for anywhere from 3 to 6 months, depending on what your comfort level is. But I think at least 3 months.
Great. Kevin, do you have any other questions for our speaker?
No, I'm pretty happy with things. This was a great review of the pediatric or management of the pediatric patient. I know I'm not a big fan of kids, and I kind of draw the line at about 10 or 12, just depending on the size of the kids. I've had some 15-year-old kids who are just so tiny that I just didn't feel comfortable managing them in the airway. And we're fairly fortunate here in Ontario where we have the ability that we can get them to the OR. The downfall is just the amount of OR time that I receive. And then, of course, over the past 2 years, just the pressures that have been placed on elective cases like ours. So, I'm not a big fan of treating kids, and the few things that I do use with any frequency, nasal atomization of Versed, and purely to get the kid to a state so that I could do venipuncture, and then put them off to sleep with propofol.
Great.
It works. It works fairly well, but then I'm not using that on a daily basis. I'm using that very infrequently.
Right. We've got. Sorry, go ahead. So we have the same issue here with OR time. It's harder and harder to bring a dental patient into the OR for procedures, and so that's why we're seeing a really big increase in office-based anesthesia and in not only pediatric offices but also in oral surgery offices too, when they have pediatric patients come by because they have a hard time getting into the OR.
Yeah.
I was very curious about the device that you presented, Dr. Giovannetti, on a total intravenous anesthesia in the intubated patient with the without the anesthesia machine and
Yes.
the CO2 filter. So let's just say from an academic point of view, if I was, talking to my anesthetist next week in the OR at a university teaching hospital, what do you think they'd say about that from a risk perspective? Are there any specific risks or disadvantages to using that versus having even a tabletop anesthesia machine?
I don't know what they would say. Probably they've never seen it and would be very skeptical. But we've used this quite extensively, and we also have our machines. But it's really the business end of an anesthesia machine. It's the CO2 absorber, which prevents rebreathing, and you don't have to run as high flows. And there's certainly you could use a circuit like a Jackson-Reese circuit and hook it up to the endotracheal tube, but you'd have to use a really high flow to prevent rebreathing of CO2. And so with this, you're scrubbing out CO2. You can run lower flows, and you can maintain your end-tidal CO2 wherever you want by assisting ventilation manually. What would you say the ideal duration of a procedure to use that device would be? I think you could use it for hours. Yeah.
Interesting.
Yeah. Yeah. Well, we have a special needs center here, and the students do all the dentistry, and we put these patients to sleep, and sometimes it takes them 3 hours to do just a couple of procedures. So that's pretty common.
So you just have to make sure the human who's handling the bag is
right.
Pumping at the right frequency, right? That's right. Yeah. I just want to take the opportunity to thank the people who've submitted questions. Obviously, I'm going to the acknowledgement of Dr. Giovannetti as a speaker will come subsequently. And I also just wanted to take the opportunity to remind everybody that if they're interested in seeing some of our previous webinars, they do exist on a COMS YouTube channel, where over the past 2 years we've accumulated a library of these webinars. So please feel free to go and take a look at topics that might be of interest to you. With that, thank you, Dr. Giovannetti. I'm going to turn things over to the person who's supposed to thank our speaker.
Thank you.
No problem.
I'm not sure if that's me or if that's Chad, but anyways, on behalf of both CDSA and CAOMS, Dr. Giovannetti, thank you very much for spending time with us. Thank you for educating us and entertaining us at the same time, and showing us some very important pearls of wisdom when it comes to managing the pediatric patient.
It's been my pleasure. I really, again, thank you so much for the invitation. This is really something that I've been looking forward to, and hopefully it was successful. But thank you so much. I really appreciate it.
Good stuff. Okay.
And thank you to everybody who've attended this evening. We had a whopping total of 90 people sign on. So good job, guys, on organizing this. Thank you, Ellen, and thank you, Stuart from McGill University Audiovisual Department for the technical support as well. And have a good evening, everybody. Thank you so much.
Thank you.
Thanks, everyone.